Sarvakareshu Sarvada. I myself, Dr. Niranjan Dharaskar and Dr. Sandeep Chaurasia, welcome you all in the city of Nagpur, recently designated as Best Indian City. Child Hospital Nagpur, Datta Megi Institute of Medical Sciences, and Physicians for Peace, US Global Organization, presents Pediatrics 2013, Books to Bedside. Today, we have beautifully crafted workshop on advanced mechanical ventilation.
Good morning, everybody. I present to you our faculty, Dr. Zimmerman sir. He has a very nice book on pediatric critical care. Then I like to welcome Dr. Foley sir. He is a intensivist, pediatric intensivist at US. I would like to welcome Dr. Robert DiBlasi sir. He is a pediatric pulmonologist, and Dr. Edward Carotin sir. And you all know our renowned sir, Dr. Dev Pujari sir, to please come on the dais.
Limiting dead space with U volumic control, adjusting the PEEP with mean arterial pressure, then to the blood flow role of surfactant, and up to the positioning of the patient, whether supine or prone. It's an excellent talk on managing the refractory hypoxemia. I have one announcement that manual of workshop and workshop kits are available at the back of this hall. Kindly collect it. Then I call upon the next speaker, Dr. Dev Pujari sir, to kindly light the samai, please. Dr. Dev Pujari sir, please. Dr. V. Thank you, sir. Dr. Christopher Foley, sir. He will talk about optimizing the PEEP in ARDS. Dr. Dr. Christopher Foley. Ventilator-associated pneumonia, Dr. Carrot can very well explain to ourselves. Patient is mechanically ventilated, positive bacterial culture within 48 hours of mechanical ventilation. Some of the diagnostic criteria such as temperature instability, WBC count less than 400, above 15,000, changes in character of sputum, apnea, tachypnea, and increased work of breathing, wheezing, rales. These are some of the diagnostic criteria, and some tips for oropharyngeal intubation, which is preferred one rather than nasopharyngeal. Suctioning of oropharynx before the intubation, and at the time of extubation will decrease the micro aspiration. Thank you, sir. One or two questions, if any.
The material and then send that for culture, but we typically do not lavage the trachea and then obtain material. At least in our unit, we don't do that.
Okay. Thank you all the faculty. The important messages which we got from the lecture. The patient synchrony with mechanical ventilator, adopt different ventilator strategies for different diseases. Don't forget to check the humidifier whether it is on or off, and prevention strategies based for to prevent ventilator associated pneumonia. Thank you very much.
We will take a 10 minutes tea break and we'll collect here for the workstations.
Thank you very much, sir. Sir has very well covered the pathogenesis of ARDS. He has talked about therapies for ARDS, and he has given the goals of management, like how much to maintain FiO2, PEEP to maintain main airway pressure, low tidal volumes, permissive hypercapnia, and how to manage airway leak. And he has very well talked about the strategies like high PEEP and low tidal volume in patients of ARDS. And he has shown results of trials also. So thank you very much, sir. I would like, if any questions from the delegates, they are most invited. So if you have any queries, you can raise your hands and can ask the questions. Thank you.
Is it not too short a period to decide whether it is working or not?
The first question was when we optimize PEEP and we're looking at it, when do we use diuresis, or when do we start diuresis? In general, we're watching how much they put in and how much they put out right from the beginning in our ARDS patients. And we don't let them get too fluid positive right from the beginning. We put them on mild fluid restriction, 75 to 80% of their maintenance intake. We try to make that usually normal saline or Ringer's lactate. We don't use a lot of half normal or lower because we don't want the free water. And in general, when they do start to retain more than they're putting out, we'll start diuretics probably in the first day or two, and try to look at that I's and O's to try and keep them neutral. If they came in relatively euvolemic, we'll let them be positive that first day if we have to resuscitate them.
septic shock, they are already requiring huge amount of fluid. There we cannot spare fluids at that point of time. So it's not in your hand to restrict the fluids in that initial first 48 hours. And then to restrict fluid, and then you said you try to restrict fluids. I mean, that becomes a slightly contradictory statement. So when do you really get onto that restriction?
No doubt about it. If you have someone with septic shock as the nidus of what's starting our ARDS, rarely do they have fluid ARDS and septic shock at the very same time. There's going to be a progression of time. The capillary leak mechanism that we see in the ARDS that forms later in the course of things. You would never sacrifice intravascular repletion and fixing shock for fluid restriction. So we would replenish these folks. They would be very edematous, recognizing that is ultimately may lead us down the road to ARDS type picture. And then we try to diurese them when their hemodynamics can tolerate it. So they're no longer acidotic. They've recovered their cardiac output. Their exam has improved. They're back to where we feel that they are euvolemic from a vascular space, even though they're going to be very edematous. And that also affects chest wall compliance and lung edema. Then we actually are set up for ARDS, and we try to pull the fluid off as they'll tolerate it down the road. But usually we're talking about a 48 to 72 hour period for the first resuscitation, and then as ARDS rears its head, then we try to take the fluid off.
You prefer bolus or infusion of like a diuretic?
We've done either. We have better luck with folks who have marginal hemodynamics to use continuous infusion of furosemide or something like that, because it has less perturbation with the ups and downs with a bolus. Most of our patients, their hemodynamics are well tolerated. We can go with bolus dosing, but that's really what we will go with a drip versus a bolus dosing. Also, net amount we'll get off will be greater with the drip than if we use intermittent dosing. So that depends a little bit. If we have to get more off them in a short period of time, we may go with an infusion instead.
Related to steroids, how do you determine it's working or not within 3 days? You said it's short course of steroids.
Right. If you look at the data mostly from Maduri and looking at late onset ARDS, within 3 days of starting high dose Solumedrol, those folks show changes in compliance. And so we may go as far out as 5 days, the lungs to become softer, more compliant, and over time that's going to be a positive result for us to try. There's hard science that is lacking here. I mean, we really are mostly going by our clinical response to the steroids. And if it's making progress, we'll leave them on, and we'll usually treat them for 2 weeks or so. But if it does not seem to make a difference, we may be too early, they're not yet in that fibroproliferative phase, or they're just not going to respond. And in those patients, we'll typically stop it after that 3 to 5 day trial and wait, maybe try again, or just continue to watch and wait. Usually once we get out about 2 weeks on the ventilator, if we're still at relatively high PEEP, and we're still having to use conservative management to maintain decent oxygenation and ventilation, then we'll try to improve their compliance with some steroids again if we haven't tried already. What we would use is the same as the Maduri protocol. It'd be load them with 2 per kilo, and it's 1 per kilo Q6.
How do you find out if the lung is recruitable or not?
Right. A lot of that is, as I said earlier, it's a trial and error. It's going to be a matter of we change ventilator settings, we go up on our PEEP, and we see if our dead space hasn't changed, we see if our oxygenation has changed, we see if our saturations have changed, as well as our blood gases. Sometimes we'll use our X-ray to help us as well, which is a very crude instrument, obviously, but we'll use a combination of all those things to tell us has it really made a difference, or if we just increased the numbers without changing the overall setting. If that's true, we've reached the max of what we're going to do with PEEP, and we'll back down to a previous setting.
Chemical alkalination, you said. You do with what and to what extent?
That is very much style over substance, what we use for chemical alkalinization to try and maintain our pH. I love THAM, tromethamine, which is a tertiary amine broken down to acetate, so it doesn't raise your PCO2. The trouble is it's no longer available. They don't make as much of it anymore, so we don't have it, which was a really nice way to try and alkalize somebody without increasing PCO2. Instead, we'll use acetate if we can in their IV fluid, which is a little bit gentler, doesn't raise their PCO2 quite as acutely, and doesn't affect the cerebral vasculature as much. And if we don't do that, if we want to do it more acutely, say someone is 7.0 or lower, then we'll usually use bicarbonate.
Thank you, sir. Hello.
You prefer gradually?
Hello, excuse me. We will have meet with the experts tomorrow, and then we will ask questions there. Thank you, sir. We will move to next topic of ventilator circuit temperature and humidification. by Dr. Robert Di Blasi, sir. Thank you, sir. It's a very important topic, has been extensively discussed by you. Nice one. We allow only 1 or 2 questions after each lecture, and we'll move to
Yes, sir. That was the 850, yeah. Oh. Okay, so don't select the non-invasive mode for any of them. Is that what you're talking about? Non-invasive and, yeah. So every patient that's receiving nasal pressure ventilation, or any patient that's receiving invasive mechanical ventilation, we always keep the settings the same. We use the invasive feature. The non-invasive feature is only intended for babies that are receiving high-flow nasal therapy, and that's it. So you should use invasive for both non-invasive and invasive. It's very confusing.
Over the water and not
I can't hear you very well, I'm sorry.
the principle is the air passes over the water
Yep.
and not through the water.
Yeah, no, it's not a bubble system, it's an evaporative system, it's passover.
Will it make a difference if air passes through the water?
So like I mentioned before, there are a number of bubble, especially in Vietnam, I noticed that there was a lot of bubble chambers that were being used to provide humidity, and you don't get any more humidity from that system than you do with a passover. So it's not preferred. It's been evaluated, and the passover system's definitely better. The bubble system is going to provide larger droplets, and those droplets will likely rain out. So, any other questions? Thank you.
Thank you, sir. One announcement is there. After the completion of this lecture series, we will have workstations. Each workshop delegate has provided the number on their badge, and from 1st to 25, then 26 to 50, 51 to 75, and 76 to 100. These are the 4 groups which we have divided, and 4 workstations will start at 11:15 after a short tea break. We will move to next topic by Dr. Edward Karotkin. How do I decrease VAP in my unit? Ventilator associated pneumonia in my unit. Dr. Karotkin, sir.
How do we open it up here? That may stimulate surfactant production. And so we feel that there are certain strategies that
We may find that the median air pressure is 14. Now, we're typically going to want to start high-frequency oscillatory ventilator at a higher median air pressure than what we were using.
sometimes even a short course of tocolytics, nifedipine or some of the other drugs may decrease the likelihood of a mother going to labor early. In our nursery, we use Curasurf. I understand that they're one of the sponsors of the meeting. But we found, I don't work for Curasurf, I don't get any money from them, but we found that in our nursery, Curasurf seems to work a little bit faster than Survana. We can get a better response. We're less likely to require additional doses if we use Curasurf, so we have virtually switched to Curasurf in all our patients. We think that smaller volumes could be used and that there's a faster onset of action with Curasurf versus some of the other preparations.
Have the ability to integrate this technology into conventional mechanical ventilator in the United States. The mean airway pressure, think of mean
13. And as you know, there's been a movement away from intubating all babies in the delivery room, and now we're much more likely to hold off on intubation except for those very small babies. So here you can see the criteria for babies less than 28 weeks gestation in the delivery room.
Are going to inflate or deflate.
Typically intubate these
keep
babies
the pressure constant
and provide them with
and also to limit
Curasurf in the delivery room within the first 10 or 15 minutes of life. We know that we're going for a high-risk delivery. We bring the CuraSurf into the delivery room. We have a special team. We connect the baby to the pulse oximeter within the first few minutes of life. We have a ventilator. We have oxygen, humidified oxygen. The ring is go. So we're all ready to go. Once that baby is delivered, within the first minute or two, that baby is intubated, and we give CuraSurf. And we have a guideline. We have a kind of like a something to shoot for, where the baby gets the CuraSurf within the first 10 minutes of life. Now, for the bigger baby, the 29 to 33 weeker, we tend not to give the CuraSurf, but we put this baby on CPAP right away.
We'll set that big CPAP level here, and
over time, we would watch, for a relatively short period of time, and if after 10 or 15 or 20 minutes the baby is deteriorating, we would intubate. So if there's any question, we would probably intubate.
And you monitor arterial ABGs, means every 10-15 minutes you do put arterial lines, or?
Well, I would say virtually all of the babies that get admitted to the NICU have an arterial line in. We put an umbilical arterial line in almost every baby, if we can, who is requiring oxygen or mechanical ventilation. Sometimes we'll put in radial lines, but I think it's so much easier to put an arterial line in. So almost without exception, if we can get one in, we put an arterial line, and sometimes even a venous line. So it's very easy for us to get arterial blood gas. You don't have any deliveries at your hospital, do you? No mothers deliver there?
No. Where I'm attending, that hospital is attached to child hospital.
Now, what if you have a 26-weeker? Do you give it in the delivery room?
28 weeks. Less than 28 weeks.
You intubate and give surfactant in the delivery room?
Not that team ready, but at least one more pediatrician is with me.
Right, okay, good.
And anesthetic is already there. So we manage that. Then we ship the baby to our hospital.
How far is the delivery room from your hospital?
Hardly 15 minutes
drive.
Yes. It's very
Shift to your right side, please.
I'm attached to Dr. Kepker Hospital, where we are following like this. What else do you have?
Shift to your right on station, clockwise rotation.
So we have to back away from that and get to it. In the past, what I talked about, we'd use airway pressure and hemodynamics. Well, that's obviously way up in the tracheal tube and looking at the body as a whole. With transpulmonary pressure measuring, we actually get a better feel for what's happening down inside the chest, in the middle of West Zone 2, where the ventilation perfusion is roughly matched, right where the cardiac and lung interface is. So with measuring that, and we'll talk about how we actually get to that number, we actually know what's happening at the alveolus, and therefore things like airway compliance and airway obstruction become negated because we can actually look at what's happening down the alveolus. Take, for instance, an asthmatic. When we intubate an asthmatic, it often takes very high peak airway pressures to overcome the airway resistance to get the lung to move, to get our 8 per kilo or 6 per kilo tidal volume. Well, we recognize that's all hydraulic, trying to get through the respiratory resistance. Because of that, we really don't worry too much about it because we feel we're protecting the alveoli because of the resistance. We don't see that necessarily in ARDS and other things, but by having transpulmonary pressure, we will have a better idea of what's happening actually down there. And so we can almost ignore, to some degree, our plateau pressure limit of 30 like we have it now. Or if we want to move our PEEP up and down, we actually have something more objective to tell us, okay, we've reached a place where it's actually keeping the lung open, or we've reached a place where the lung is collapsing at expiration. Okay. So I'm going to hand things over. We'll talk about how we measure it, and then we'll talk about how.
But there's all kinds of patients that this will work very good with the normal system.
This guy feeding. Next. Does anybody work with this system at the moment? No. Okay, alright. Bed ventilators, bare ventilators, remember them? Yep. Well, this one is from that heritage. So this is what they've replaced it with. So, you would select pediatric population, nasogastric balloon, and X. Now, before you put the feeding tube in, you need to test the integrity of the balloon. And you do a binary response, pass or fail. And then insert the
when you're in the appropriate place, you would see the cardiac oscillations on your esophageal pressure waveform. See there, on this waveform? This is typically what you would be looking for. On that, in the X-ray or some other chest X-ray is going to be the gold standard.